Good evening, one and all, and welcome to this program on prescribing in the face of CKD, and I'm going to talk about AKI as well. Um, Mr. Austin is on to help us out tonight on the technical side, and I'm Dr. Margaret Fitzgerald, here to put together the presentation. So I'm thrilled that you're with us. Just a couple of things. One is belated Happy Nurse Practitioner Week, one and all. I hope you got a few moments to kind of bathe in the glory of our special week. And the other is just in case I don't get to it at the end of the program, I wish you all a wonderful Thanksgiving. It's a very special time of the year. So with that in mind, let's get going. And one thing that I would ask is questions for me go in the Q&A box. Technical issues go to Mr. Austin in the chat. And he will be adding some really, really wonderful documents from our partner TRC that you can share with students, print out yourself. You have the copyright ability to do that, and we want to give that to you as a value added. Many of you have been on all, if not most, of these pharmacology sessions for faculty, but just one more time, in case anyone hasn't been on before, I'm the founder of Fitzgerald Health Education Associates. My clinical practice has been in a federally qualified health center in a small city about 30 miles north of Boston, where I see literally everything that comes through the door. The babies, the people in the middle, the people who are older. It's true multi-generation family practice. I'm also on faculty at Case Western Reserve University in Cleveland, which is where I did my doctoral studies. I sit on the editorial board of a number of different publications, and I'm a member of the Pharmacy and Therapeutics Committee for a major HMO based out of Boston, Mass General Brigham Health Plan, and I'm the only nurse practitioner who sits on that P&T committee. I've also taught graduate level pharmacology for more than 35 years now, which I can't believe I'm even said it was that long, but it really is a passion of mine. Disclosures: no real or potential conflict of interest to disclose, no experimental or investigational use of drugs or devices will be presented. And if I say something about off-label drugs, I'll identify it as so. And the references will be found within the presentation. Now, this is one, you know how when we're dealing with students in particular, well, and dealing with ourselves as busy clinicians, folks want that one place to go to get kind of the real scoop on things. And what I would really suggest is having people be well familiar with what's going on at kidney.org. And that's the National Kidney Foundation. Now, if you just go to kidney.org, you're going to get things for consumers. You're going to get a request to make a donation because it is a nonprofit, very good organization. But there is a tab at the top for professionals. And that's where you will get into their clinical practice guidelines, which are easy to navigate, I find, downloadable. And the other part of it is, which I really like, they get updated on a fairly regular basis. So teachable moment. How do I know what medications are safe or not to prescribe in CKD? Well, what you have to do is start with the evaluation of kidney function. So CKD defined is the abnormality of kidney structure or function present for more than 3 months. So that's really important. More than 3 months, not something temporary with implications for health, usually with a GFR of less than 60. Now, some labs, when you order a creatinine, will give you automatically an estimated GFR. And what happens quite often is if the GFR is less than 60, you get a number, like the GFR is 58, okay? But if the GFR is even like 61, What it will just, the lab will often say is GFR greater than 60. Okay. And so that could lead somebody to think that as long as the GFR is above 60, everything's cool. But you know what you have to do at the same time? You need to consider age and birth sex assignment and estimated GFR assessment. So here is something to think about. The average measured GFR by age in people without CKD. So when people are in their 20s, their average GFR should be like 110 plus. Okay. And then you could see as we get older, the GFR, the average GFR by the time people are in their 40s is just under 100 at 99. And then you see 50 to 59, 93, 60 to 69, 85, and then 70 plus. The average GFR will be in the mid 70s. So one point I like to make when I'm teaching pharmacology is if a patient is 80 plus years old and has a GFR of 60, well, let's say 62, 63, fine, fine. No doubt that person has enough functional nephrons to get through the rest of their natural lifespan. But if you've got a 40-year-old who's already had 10 years of hypertension and their GFR is 61, no, that should be almost 99. And that person has kidneys that are, I don't want to say aging, but they're not in great shape for somebody of that age. So I believe it's incredibly, incredibly important to put things in perspective on GFR. And that's why if I'm ever dealing with a lab that simply does GFR greater than 60 for when I order like a chem profile or whatever it is, particularly for my patients with hypertension, dyslipidemia, and diabetes, the big three for damaging kidneys, I calculate out their GFR. I just don't go with that. It's above 60 and let it go with that. So here's the same serum creatinine and the different estimated GFR. Now, this is also something I want to remind you. Feel free to share these materials with your students. Just give attribution. That's all I ask. So if a serum creatinine of 1.2 in a 22-year-old man and his estimated GFR would be 88. So he actually would be considered to be stage 2 CKD, mildly decreased GFR, because we'd expect that GFR to be more like 110 plus. Okay. 58-year-old man with a creatinine of 1.2, his GFR is 66. Well, I've seen worse. We've all seen worse, but I'm not really amused with that either. And an 80-year-old with a GFR of 1.2, the GFR is 46. And that's stage 3A, mildly to moderately decreased kidney function. So when looking at the stages of CKD based on GFR, stage 1, 90 plus, to which you might say, well, why the heck are we even talking about this being a stage of kidney disease if it's normal kidney function? But these are folks who typically have risks for CKD development, like hypertension, type 2 diabetes, dyslipidemia. And at this point, what do you want to do? Remember, blood vessel health equals heart health equals kidney health equals brain health. We're all a bunch of blood vessels. So control cardiovascular risk factors. Stage 2, GFR is typically 60 to 89. And at this point, mildly reduced kidney function, treatment observation, treatment of blood pressure and other cardiovascular disease risk factors. Okay. Now, when you get into stage 3 CKD, with stage 3A, the GFR is 45 to 59, and 3B, it is 30 to 44. And this is the stage, particularly stage 3B, that sometimes there is a need to alter medication doses. And I'm obviously going to talk about that. But at this point, particularly stage 3B, this is about the time to get a nephrology consult going as well. Stage 4, the GFR is 15 to 29. It's generally considered by the time somebody is to stage 4, they've lost 75% of their renal function. And many meds will require an adjustment in dose, special monitoring. Some require discontinuation. Definitely nephrology consult if not already done. And this is the time when the discussion needs to start on what would the person want to do if the renal function gets that much worse and they would require dialysis or renal replacement therapy. Now, one of the things with people with stage 4 GFR is generally when they're in the mid to like high 20s, they can often be remarkably healthy human beings. One woman in my practice, pushing 90, who, thank you very much, has had hypertension, type 2 diabetes, and dyslipidemia for about 40 years now, but very adherent to medication, physically active lifestyle, non-smoker, doesn't drink any alcohol, has done remarkably well with all of this. But she's got a GFR of like 25 now. She is adamant. She's in her late 80s, adamant she will never, ever, 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 ever go on dialysis. Adamant. She believes that this is she's a woman of great faith, and she believes that this is in the hands of the divine. This is the plan. And she's running around going to, the senior center and volunteering at her church and that type of thing. And she really feels quite well. You'll oftentimes run into people whose GFRs are in the mid-20s and they don't feel particularly good. They don't. And part of it is their body is having such difficulty removing its waste. So it's really quite variable. I've seen patients with GFRs in the mid-20s who were significantly anemic, because this is when the anemia that goes along with CKD usually kicks in as the kidneys function less erythropoietin, one of the many mechanisms of the anemia of chronic disease we see along with CKD. And then I've also seen people with pretty much normal hemoglobins. So it's really quite variable. And then at this point, stage 5, the GFR is less than 15. Severe or end-stage kidney failure. And one more time, renal replacement therapy, aka dialysis, transplantation, or end-of-life care. By now, many meds need a significant adjustment. So what's one of the first rules when we're dealing with renal function is first, try to preserve it. The kidney is not the liver. You can really bang the liver up quite badly, and you can destroy like 3/4 of it and it will regenerate. You can't do that with the kidney. When it's injured, when there's permanent damage to the kidney, that's it. Nephrons do not come back. So trying to preserve renal function is absolutely key. So what's the leading causes of CKD? Hypertension and diabetes. No new information here. And what can be done to preserve renal function? So hyperinsulinemia, what do we know when we're thinking of core pathology in disease? Is that hypertension, particularly with type 2 diabetes, these are diseases of insulin resistance. And what are some of the consequences of hyperinsulinemia? Difficult to control high blood pressure, because hyperinsulinemia enhances renal sodium absorption, sodium reabsorption. And this is key with teaching, of course, is to have people conceptualize the pathophysiology about why somebody with hypertension and type 2 diabetes has such difficulty to control blood pressure. Okay. So what meds can be used to counteract that? And this would be the thiazide diuretics. And if you recall, if you were on with me for the hypertension program that I did, remember, we are the oddest people in the world in that we are a nation of hydrochlorothiazide users. The rest of the world for thiazide diuretics uses chlorthalidone. Chlorthalidone, it can be magical for treating people who have hypertension and type 2 diabetes. It is a more potent thiazide diuretic in part because of the pharmacokinetic principles of higher bioavailability and longer half-life when compared to hydrochlorothiazide, and you get more blood pressure control out of it. Acanthosis nigricans, believe we're all familiar with this, the cutaneous of hyperinsulinemia. And then just keeping in line with what we should be aware of is cutaneous issues look different according to different skin tones. On the left, we have a person with a lighter skin tone. We're actually looking at, we're looking at the axilla there. Wasn't sure which image I used. We're looking at the axilla there, and you can see what the acanthosis nigricans looks like on lighter skin tone. And if you look really, really carefully in that, you'll see some skin tags, and those are very, very common among people with hyperinsulinemia. On the right, this is what acanthosis nigricans with many skin tones, skin tags can look like in a person who has a darker skin tone. Questions I often get from patients is, can this discoloration of my skin ever go away? It actually can improve with treating the insulin resistance, particularly if it's obesity associated. Retinoids can be used on it too. There are a number of different things that can be done to lighten the skin tone. So endothelial dysfunction via reduced nitric oxide production. This leads to vasoconstriction, sympathetic nervous system activation, platelet aggregation, altered vessel membrane permeability, and subsequent microalbuminuria. What meds counteract this? And ACE inhibitor, ARB, calcium channel blockers. And, that's when, since we're all helping out NP students with the microalbuminuria, very often people will say, oh, good, microalbuminuria. I know the answer to that one. It's ACE inhibitor or ARB. And actually, the correct answer is yes, ACE inhibitor or ARB as part of improved blood pressure control, dyslipidemia control, and blood sugar control. In other words, make those blood vessels happier, because that's why protein is leaking into the urine, is because of the endothelial dysfunction. So, but this is something that confuses particularly the novice, and for that matter, it confuses experienced clinicians. I thought ACE inhibitors and ARBs were potentially provided renal protection, but they shouldn't be prescribed in renal stenosis. Well, make up your mind. Which way is it? Well, teachable moment. Pathophysiology leads to better understanding of the impact of drug therapy. So this is a good citation on this. So the ACE inhibitor, the ARB, are they renal protective or potentially problematic? So when the one time that ACE inhibitors or ARBs should be used with either great caution or potentially not used at all is in the presence of renal artery stenosis, particularly bilateral renal artery stenosis. So how the heck could you figure out whether somebody comes in with renal artery, particularly bilateral renal artery stenosis? Well, one clue would be, because it's an asymptomatic state as a general rule, an unexpected increase in serum creatinine of 0.5 to 1 milligram per DL after starting an ACE inhibitor or an ARB, and or the presence of a renal artery bruit. I'm going to tell you, you've got to be pretty slender before you can pick up a renal artery bruit on abdominal auscultation. It's not impossible, but you know, think more like the younger adult who has a BMI of maybe 22. Yeah. The older adult with a BMI in the 30s, probably not because of the abdominal fat pad. So I'm going to give you two examples, the two case examples of renal artery stenosis. And so case example one, 32-year-old woman in good health, BMI is 24, non-smoker, normal lipids, family history of hypertension. Both her grandfathers developed high blood pressure after age 60. So that's significant, but it's, you know, it's not alarming. No medications except she's on combined oral contraception. And her physical exam today reveals a BP of 168 over 105. Now she feels fine. This is an incidental finding. She's in to like get her birth control pills refilled or something like that. And a year ago, her blood pressure was documented as being normal. All right. So what do we have here? She's not obese, not a strong family history of hypertension, and a marked difference in her blood pressure 1 year to the next. Because what do we usually see with people as they develop hypertension? It's little by little by little. It's not like you go from 110 over 70 1 year to 168 over 105 in 1 year. She has bilateral renal artery brewing. She's slender enough that you can hear it. Likely etiology. So now what you have to do is say, what has given an otherwise well young woman this marked elevation in her blood pressure so quickly? Well, two major causes of renal artery stenosis are fibromuscular dysplasia, an autoimmune condition where there is thickening of the renal arterial wall that gives you a physiologic renal artery stenosis, but without atherosclerosis, or atherosclerotic disease. Okay, well, I'm thinking not atherosclerotic disease, no. Or could this be because we know birth control pills can bump up the BP? Well, you know what? Oral contraceptives can bump up the BP a tiny, tiny, tiny bit, not like this. So what it ended up being was the fibromuscular dysplasia, most common in younger females. And this is how it presents. All of a sudden, BP fine 1 year, high the next year. Okay. So this would be a person you don't want to go within a country mile of her with an ACE inhibitor or an ARB. I'll talk some more about what next steps would be for her in a moment. Okay. Now, renal artery stenosis, case example 2. This is the more common. The young woman, that's the zebra. You might see that once or twice in an entire career. But the second one you see on a regular basis. 65-year-old man, former smoker, 50-pack year history, type 2 diabetes, dyslipidemia, 30-year history of hypertension, on an ACE inhibitor, hydrochlorothiazide, calcium channel blocker. Historically at BP goal, his BMI is 38. You're not going to hear a renal artery brewery on him. A1C and LDL are at goal. BP today is 172 over 105 on current therapy. But he's highly adherent by history. His BMI's high, yeah, but his BMI's been high for years like this. So he has no new risks for poor blood pressure control. And he's adherent to therapy. So likely etiology, one more time, getting folks to think of that clinical application of pathophysiology. Do you think this is fibromuscular dysplasia or more likely atherosclerotic disease? In other words, atherosclerosis in the renal arteries. And it's atherosclerotic disease. This makes sense, doesn't it? And this is one of the diagnoses that needs to be kept in mind when a person like this gentleman presents who's had longstanding, well-controlled hypertension. All of a sudden, blood pressure control is out of whack. So clues to renal artery stenosis, that rapid deterioration of kidney function when started on or having a dose increase of an ACE inhibitor or an ARB. As I mentioned before, if the serum creatinine bumps up equal to or greater than 0.5 to 1 milligram per DL, proximal to starting a dose or a dose increase. So one key point to keep in mind is that routinely people on ACE inhibitors and ARBs should have serum creatinine and potassium looked at periodically. So monitor serum creatinine and potassium at baseline, follow up in 1 to 2 weeks after starting or increasing an ACE inhibitor or ARB dose. And what if there is a really significant bump up, or if there is a bump up in the serum creatinine after starting an ACE inhibitor or ARB use? Leave it be, leave the drug be if the serum creatinine bumps up by less than 30%. This is an anticipated effect that usually dissipates within the first few months of use. And as the blood pressure improves, the serum creatinine often normalizes. And then recheck creatinine, potassium, and BP in 2 to 3 additional weeks. If stable, then monitor once to twice a year, or the change of advance or clinical condition. Now, I have to tell you, this is aspirational to do all this monitoring. Sometimes we settle on what the patient's able to do. So getting back to this whole thing, ACE inhibitor, ARB, renal protective, potentially problematic. One thing we do want to keep in mind with ACE inhibitor or ARB dosing and hypertension, particularly with type 2 diabetes, you want to give them the maximum tolerated dose in the presence of urine albumin to creatinine ratio. And an example of that would be like lisinopril 40 milligrams a day. That lisinopril is on the $4 drug list. So I like cheap drugs. I practice in a low-income community. And that for $4 a month, they can get lisinopril 40 milligrams. Wonderful, wonderful. It's a true once-a-day ACE inhibitor. True. Enalapril with intact renal function is really more like a twice-a-day ACE inhibitor. Candesartan, telmisartan, a couple of other examples on this one. And if you're saying, well, wait a minute, the ACR is a little off, but the blood pressure is good, and they're on 20 milligrams of lisinopril or 40 milligrams of telmisartan, if I bump up the dose, will they get hypotensive? Probably not. Probably not. So, and so this is just a little bit more on defining the albumin to creatinine ratio and how that can be categorized. One point to keep in mind with this is it might look like a little bit of overkill with categorizing the microalbuminuria or macroalbuminuria or whatever. Reimbursement for visits gets better the more that you can put in for diagnostic codes. It's the way things go. So true or false, a lower dose of an ACE inhibitor or an ARB should be considered in a patient with CKD who is acutely or chronically renal volume depleted, or acutely or chronically volume depleted due to the hyperkalemia risk. And that's actually true. So please keep that in mind. According to the ADA and the National Kidney Foundation, ACE inhibitor or ARB meds are not necessary in patients with diabetes and albuminuria in the absence of elevated blood pressure. So that rare person with diabetes who does not also have high blood pressure, but does have some albumin in the urine. And that is a resounding false and should be used with persistent albuminuria, even with normal BP. And if you dig through the ADA guidelines and you find that, one more time, rare person, age 40 and up, even if the kidney function looks decent and their blood pressure is good, ADA advocates for having an ACE inhibitor or an ARB on board. You're not going to make them hypotensive. Thiazide diuretics, true or false, are less effective when the GFR is less than 30, but loop diuretics like furosemide remain effective with lower GFR. And that is true, but the hypertension guidelines are written all over it. Do not use loop diuretics to treat high blood pressure unless there is like something like concomitant heart failure or a GFR of less than 30, and you really need help getting rid of fluid. Because this is something I find the students like. Where does the trade name Lasix comes from? Last 6 hours. Yeah. So it's a loop diuretic, does a great job of pulling fluid off if you've got enough kidney to have it work, but it's not around long enough to give you much in the way of blood pressure control. All right, so KDIGO clinical practice guidelines for diabetes management and CKD. They also recommend the use, this is a new-ish recommendation, not new, but probably one of those recommendations that will not necessarily crop up on boards because it is not exactly one of the first line hypertension meds, but the use of a non-steroidal mineralocorticoreceptor antagonist with proven kidney and or cardiovascular benefit in people who have type 2 diabetes, GFRs of 20 or greater. Why not below that? Because of the hyperkalemia risk. Their potassium is okay. They have evidence of albuminuria despite maximally tolerated dose of a RAS inhibitor like an ACE inhibitor or an ARB. So teachable moment. Newer meds in a class are often a refinement of prior approved drugs in that class. So these are the MRAs. So they include drugs like spironolactone, aldactone, been around since, I think maybe since I was in my RN program. We won't get into how long ago that was, but I remember aldactone from 1,000 years ago, and most widely used in heart failure, end-stage liver disease, hypertension, acne, female birth gender assignment only, and male to female gender affirming care. Now, this is interesting. So why does spironolactone? It does not have an FDA indication for it, but it has been demonstrated to be helpful in females with severe acne. And the reason is it's an androgen blocker. And that's why it's used in M to F gender affirming care. All right. Cheap, $10 a month. Its derivative, Inspra, more receptor site specific than spironolactone, less anti-androgen effects. So it's not used in gender affirming care. It's not used to treat acne. It's $25 a month. And then Kerendia, which is the newer member of this category, is the one that the National Kidney Foundation, the ADA, are really talking about as more potent and receptor site specific than the other two in the category. It's also pretty pricey. It's also $600 plus dollars a month. If you're adding a potassium sparing med like an MRA to a person on an ACE inhibitor or an ARB, you have to watch their potassium like a hawk. You need to check it 3 and 7 days after initiation, and then every month for 3 months, and then every 3 months or sooner if clinically indicated. And then monitor creatinine as would be indicated by overall clinical scenario. In fact, I've had this discussion with patients who don't like coming in for lab work, and I'll say, well, there is another drug that we could try on you to help with your blood pressure, help preserve the kidney function you've got and everything. But here's the deal. You got to be in here for labs 3 and 7 days, and then every month for 3 months. And I've had patients say to me, well, I'm not going to come in and do that. And that would be acceptable then to document that you offered, but they are unable to commit to the extensive lab monitoring, because the last thing you want to do is send somebody out with a potassium sparing product with, like, 3 months worth of meds, and I'll see you back then, and have them land in the hospital with a potassium of 6, because that can happen. So we've got a 58-year-old guy without complaint, known to have hypertension for the last 18 years. And since he was 18 years of age, sorry. No therapy for 3 years. Remember, it's always hard to make an asymptomatic person feel better. High blood pressure is asymptomatic. He has grade 2 hypertensive retinopathy and S4 heart sound, grade 2 over 6 systolic murmur. His PMI is shifted at the 6th intercostal space midclavicular line, and his BP is 170 over 110. So he obviously has evidence of hypertensive target organ dysfunction with all these physical exam findings, but he feels great. And are his renal issues likely acute or chronic? Okay, good learning exercise that feel free to use. And of course, they're chronic given the history. He's had high blood pressure for 40 years and he's only 58 years old. His fasting glucose today is 180. His A1C is 8%. Actually did not know he had type 2 diabetes until this visit. HDL 32, LDL is 170. Triglycerides are 280. Creatinine is 1.6. And he has 30 milligrams per DL of protein in his urine. So he has macroalbuminuria. Okay. So with his the current GF National Kidney Foundation calculator, which I suspect you're all aware of this, they took race out of this calculator 3 years ago. It was a few years ago. It might have been a little bit longer than that. And if male, regardless of ethnicity, his GFR is 50, his 3A, stage 3A CKD, he has lost 50% of his renal function. If female, regardless of ethnicity, the GFR is 37. Oof. Stage 3 B CKD with about 60% of renal function loss. And I just need to say one more time, it's lost, gone. It is not coming back. So is adding an ACE inhibitor, an ARB, or an MRA enough? No. Obviously, he needs improved glycemia control, lipid control, and hypertension control. Why does he have protein in his urine? He has profound endothelial dysfunction. So what to the KDIGO guidelines for type 2 diabetes and CKD, first line meds for hypertension with CKD and type 2 diabetes. Let me share a little nugget with that I recently picked up on from teaching some folks who were really struggling with the type 2 diabetes drugs. Okay. It was a group of students I was working with, and they were looking at, like, metformin is first line for diabetes, and then everything else for type 2 diabetes is second or third line, and having a great deal of difficulty conceptualizing that. And when I said to them, what we have to do is think that for contemporary type 2 diabetes care today, we need to think metformin, the GLP-1 agonists, and the SGLT2Is are all first line. And what we use just depends on the diagnosis. And do you see me pretending that it's easy to get these paid for? Yeah, I am. But they, so, and when I did that, they went like, oh, that makes it a lot easier. It's kind of like with hypertension. What do we say? Calcium channel blocker, ACE inhibitor, ARB, thiazide diuretics. They're all first line. Yeah, because they are. So I found that they kind of caught onto it. So the first line drugs for somebody like this with type 2 diabetes, CKD particularly, and with hypertension, metformin, SGLT2I, statin, RAS blocker, ACE inhibitor, ARB, additional drugs with heart and renal protection, GLP-1 agonists, the non-steroidal MRA, and of course, antiplatelet therapy. So this is the SGLT2Is are the darling of people in nephrology, and they really are pretty amazing. One of the things we have to keep in mind is that as the kidneys are more damaged, the SGLT2Is do less to lower the blood sugar. It makes sense, doesn't it? Because how do these drugs work? They work by causing, they work in type 2 diabetes by causing the offload of glucose. But here's the deal. As the GFR goes down, less glucose is offloaded. But what's really important to keep in mind is you leave them be because the renal protective effect continues, even if you're not getting a lot of sugar control out of the SGLT2Is. So, true or false, there's no need for dose adjustment and statin therapy until the GFR is less than 29. So that would be stage 4 CKD. And that is true. And even then, this drug class can be used with dose adjustment. Risk factors for low nephron number include female birth sex assignment, short adult stature, small kidney size, and low birth weight. And that's also true. That's also true. So with metformin, the KDIGO guidelines say that we want with metformin, use as long as the GFR is greater than 30. So again, down to stage 4 CKD. Discontinue below 30. Is that because the drug is nephrotoxic? It means because it's renally eliminated. So lactic acidosis is a risk. The lactic acidosis caused by metformin is blessedly really rare, but it can carry about a 40% mortality rate. And that it usually only happens with super severe CKD, like stage 4, and dehydration. The other thing that you want to do is even when people are cruising like in the 30s and the 40s with their GFR, and you're going, okay, it's still okay to use the metformin, make sure that you consider advising about a sick day. If they're going to be dry, they're going to have reduced circulating volume, temporarily discontinue the metformin. That sometimes shows up on boards. Just saying. So pioglitazone use. These are metformin and pioglitazone are really underutilized meds in diabetes. What percentage of deaths in people who have type 2 diabetes will be related to atherosclerotic cardiovascular disease? 70%. And what's the evidence of ASCVD reduction with metformin use? Yeah, about a third, 1/3 or greater MACE, major adverse cardiovascular event risk reduction with the use of metformin. And the reason I mention this is because people are very excited, rightly so, with the SGLT2Is, the GLP-1 agonists, great. But I'm also hearing some people saying, so we don't bother with metformin anymore. Bother with metformin. It's a wonderful drug. It's only $4 a month. And then people say, yeah, but people get gas and diarrhea from it. Metformin is like a little miracle. It's a prebiotic. It increases healthy gut flora. That's why people get the gas when they first go on it. Prescribe extended release only, largest meal of the day. Take your time titrating it up. Take your time. And that's what I do. And I almost always can get people to tolerate metformin doing it that way. So Michael informs you of the following. He works rotating shifts in a warehouse. He operates a forklift truck. He uses a ladder to reach some shelves. In other words, Michael is a fall risk waiting to happen. And so, true or false? Sulfonylurea use and advanced CKD, particularly in the person who eats at irregular intervals, presents a significant hypoglycemia risk. And that is true. That is true. So obviously, we know that Michael would be a great SGLT2I candidate. He'd be a horrible sulfonylurea candidate, like if paying for meds was an issue. So is sulfonylurea a reasonable choice for Michael? No, given the hypoglycemia risk and the nature of his work. And we need to really, really help protect his kidneys. And CKD is an independent risk factor for hypoglycemia due to multiple factors, and hypoglycemia in the presence of increased ASCVD risk, which he has higher risk for stroke and MACE, and we don't want to do that to him. So true or false, according to the ADA guidelines, the use of the following meds contributes to hypoglycemia risk, particularly in CKD. Yes or no? This is a nice little exercise to do with your students. So metformin, no. The gliflozins, the SGLT2Is, no. The GLP-1 receptor agonists, no. TZDs, no. Sulfonylureas, yes, because it is constant insulin release, regardless of what blood sugar is. Insulin, well, yeah, of course. The DPP4 inhibitors, no, because that's smart insulin release. And the GLP-1 RAs as well are smart insulin release. Okay. So true or false? Well, I kind of gave this away already, but you've got these questions if you want to share them with your students. Less glucose lowering effect is noted with SGLT2I use. With CKD, particularly when the GFR is less than 60. And that is, of course, true. The ADA advises that the ASCVD and renal benefits noted with SGLT2I and GLP-1 inhibitor use continue to be noted in the presence of CKD. Yes. And you know what that's saying is that, like I said a few minutes ago, even if you're not getting the blood sugar lowering effect out of particularly the SGLT2I, leave them on the med. So what to watch for in CKD and SGLT2I use? Monitor BP. Remember, this drug class is a mild diuretic. BP can drop, but most of the time these people have such difficult to control blood pressure. It's not that big a deal. Increase water intake to help avoid circulating volume constriction. Don't flood yourself, but be aware fluid demands increase. With the concurrent use of a loop diuretic, then generally need to do a very careful dance between the doses of either of the meds. Probably bring the loop diuretic dose down. Anticipate with this therapy, there will be a drop in estimated GFR within about 4 to 6 months of use. And again, continues to be renal protective with evidence of overall CKD and diabetes outcomes. With advanced CKD, when to discontinue or not and why, consider the ACE inhibitor, the ARB, and the MRAs because of the hyperkalemia risk. That's the reason for it there. So we've got an 86-year-old woman with hypertension, type 2 diabetes, dyslipidemia, at treatment goal with each condition. She has a 30-year history of hypertension, 25-year history of type 2 diabetes and dyslipidemia. GFR is 29. She has stage 4 CKD. Her current meds include an ACE inhibitor, clothalidone, DPP4 inhibitor, and a statin. Okay, so let's take a look at this. So DPP-4 inhibitor, think of that as like a smart sulfonylurea, that it is going to allow insulin release, but only when the blood sugar goes up. And ACE inhibitor chlorthalidone, self-explanatory, but look at her potassium, it's 5.7. So she's hyperkalemic. So according to National Kidney Foundation, most people with CKD, the ACE inhibitor, the ARB, can be continued if the potassium is 5.5 or less. Okay. And general rule, if the ACE inhibitor or ARB are ever discontinued in the presence of CKD, it's because of persistent hyperkalemia. So drug-induced hyperkalemia with ACE inhibitor or ARB use, typical reason is reduced circulating volume, and this could be overdiuresis or underhydration. This is a woman in her mid-80s. The first thing that pops out to me is chlorthalidone is an awful muscly diuretic for a person of that age. Reduced GFR, the hyperkalemia, the risk increases rapidly once the GFR is less than 30. Hers is 29. In advancing age, I look at this and go ding, ding, ding. We're ticking off all three there. So when we look at this, she doesn't have a lot of nephrons still working. GFR is 29. She has no interest in ever going on renal replacement therapy / dialysis. Obviously will not be a candidate for transplant if her, renal function worsens. So you might look at this with a potassium of 5.7. And this is a great conceptual little exercise that you can use with your students. What's the med you should discontinue? You might say, okay, she's hyperkalemic. What's the one potassium sparing med there? It's an ACE inhibitor. But what should you consider discontinuing? The chlorthalidone. And the reason for this is it probably has a little bit too much muscle as a diuretic for her. And what do we know about older adults? They tend not to drink a lot of fluids, correct? So meds to add if BP control is improved BP control, or obviously you're going to take away one of her blood pressure meds. Let's say her blood pressure now is in poor control. Low dose dihydropyridine, like 2.5 milligrams of amlodipine. Okay. And you know what? I've done this a number of times with older adults, is discontinue their diuretic. And much to my surprise, their blood pressure doesn't budge much. And I don't need to add another drug. So if we can get rid of a drug, yay, let's get rid of a drug, right? All right. So this is just a reminder about the hyperkalemia risk with CKD and ACE inhibitor use, and about educating people on sick day rules, just like you would with the metformin. So now her prior meds were ACE inhibitor, chlorthalidone, DPP-4 inhibitor, and a statin. Her current meds include an ACE inhibitor, DPP-4 inhibitor, a statin, and she actually went on an SGLT2I. Was not at all interested in GLP-1 agonists, and I realize one of them is PO. It takes a little bit of work to get people up to an appropriate dose with the one that is oral. Not a single interest in her body about a shot. No. And with getting rid of the chlorthalidone, her potassium was 5.1, so that's okay. And her A1C was 7.8, which is perfectly fine for an older adult with significant comorbidity. Oh, but now, unfortunately, she develops a UTI. She's clinically stable. She's going to be treated as an outpatient. So remember, we've got that GFR of 29. She's stage 4 CKD. And urinalysis, culture, and sensitivity ordered. It confirms the diagnosis. What do you want to do for additional labs? And at bare minimum, a chem profile to check her GFR and then her electrolytes, particularly sodium and potassium. Because what does the aging kidney do when a person is stressed with something like a UTI? The aging kidney tends to waste sodium and retain potassium. That's what it tends to do. And pre-illness GFR was 29, as we know. And what are you going to do for a sick day rule? Advise her to discontinue her ACE inhibitor for the duration of the illness until she's really back to good hydration. And you might say, oh, that sounds like a kind of a complicated thing to do. Yeah, it is a little complicated, but you know what? It might keep her out of the hospital. So another view of the aforementioned patient, she develops urosepsis, dehydration, acute kidney injury, is hospitalized. If she had been on metformin, which she shouldn't have been, discontinue metformin, SGLT2I, and the RAS, and restart when back to baseline renal status with adequate hydration. So what about antimicrobial dosing in CKD? So teachable moment is antimicrobial dose adjustment in advanced CKD is variable according to drug class. So with the fluoroquinolones, the drugs with the fluoxetine suffix, you actually don't lower the dose, you increase the dosing interval. So one of the things is if the GFR is less than 20, you could dose levofloxacin every other day. And then avoid if the GFR is less than 10. And this is oral ciprofloxacin. I want to point one thing out to you here. Do you notice how this is creatinine clearance and not GFR? Older meds, often their renal dosing or their dosing in CKD will be expressed in creatinine clearance and not GFR, because those were the standards with the FDA at the time the drug was released. So you could see here with the creatinine clearance of 5 to 29, which somewhat approximates GFR, but not that great. The dosing is every 18 hours. Every 18 hours. All I could think of is some poor nurse trying to figure out how to dose something every 18 hours. Now, this is a good example with Cipro, with an end-stage renal disease with intermittent hemodialysis or peritoneal dialysis. You administer the drug after dialysis on dialysis days, 250 to 500 milligrams every 24 hours. Why do it after dialysis? Because this is a drug that is dialyzable. It can be pulled out by dialysis. One thing with the cephalosporins, and here's an example with cephalexin, is you can give these until there's like one functioning nephron left. With super, super, super low creatinine clearances of like 1 to 4, you can still do it. You just up the dosing interval every 48 to 60 hours. Obviously, if you've got somebody whose renal function is that impaired, you've got nephrology involved, the PharmD should be involved. So general rule in advanced CKD, the beta-lactam antibiotics like the cephalosporins and the penicillins, there's little dose adjustment needed there. So true or false, according to the Beers criteria, nitrofurantoin, macrobid, should not be used when the creatinine clearance is less than 30. And that's true because the med's not well enough concentrated in the urine with renal disease that advanced. And what do we use nitrofurantoin for? To treat UTIs. So drug-induced hyperkalemia can be an issue. Trimethoprim sulfamethoxazole is an excellent drug to avoid in people with CKD because the trimethoprim part of it is structurally similar to a potassium-sparing diuretic. And what it will do is you can end up with a drug-induced hyperkalemia. And so this, but you also need to use, one more time, try to avoid trimethoprim sulfamethoxazole and CKD, Bactrim. and use it with caution when people are using other potassium-sparing drugs like an ACE inhibitor, ARB, or an MRA. What about oral anticoagulants like DOACs, warfarin use in CKD? A person with CKD is twice as likely to develop atrial fib when compared to an individual with similar comorbidity but without CKD. So a lot of these folks end up on DOACs. And when you look at the DOACs, FDA approved for use in CKD stages 1 through 3 include drugs like apixaban, all these ABAN drugs there, and that apixaban is and rivaroxaban are likely the most widely used with very advanced kidney disease. They're also approved for use with hemodialysis. Psychotropic drugs in CKD, with most, there is little to no dose adjustment until you get to stage 4 to 5 CKD or with dialysis or renal replacement therapy. Nephrology consults. When should you do this? Poor blood pressure control on 3 or more meds at optimized or tolerated doses, including maxed out ACE inhibitor, ARB, particularly with an SGLT2. I added stage 3 to 4 or 5 CKD, rapidly progressing disease within 6 months, estimated GFR drop of 25% or more, or the creatinine bumping up, family or patient request, and others. So in conclusion, we want to preserve CKD by preserving renal function. Few meds are nephrotoxic, but many, if not most, are renally eliminated. So I want to thank you for your time and attention. Thank you, Brian, for holding down the fort on the technical side. And I'm going to take a quick look here and see if anything came in on the chat, and make sure that you feel free to share the information that I did tonight with your students. And I'm also going to take a quick look over here to the Q&A box. If you're wondering where that is, that's where I'll take questions. Go over to the bar at the top. There's 3 dots there. Click on there. The Q&A is there. And I'll be the only one that can see your question. You know, something I do know from working with nurse practitioners, students, and particularly getting ready for boards, sometimes the transition from the RN role to the NP role is a tough one. And what do we all know? 3/4 of them will graduate as family or adult gero NP, primary care NPs. So they're most often going from the acute care setting to the primary care setting. And they're really baffled about what they see in the acute care setting and how it translates to the primary care setting. And what I also find is that I advise them as they're taking care of their patients in the acute care setting. I really advise them, think of how you, as a nurse practitioner, will care for this patient when they're back out in the community. Okay. And that's really, it does 2 things. One, it helps them conceptualize the role. The other part is that it also gets them more engaged in assuming the role responsibility of being a nurse practitioner. In my pharmacology class, I'll have students write a paper about a patient they might have seen in the acute care setting and how they would do exactly this out in the community. When the patient gets discharged, to choose a couple of the meds, focus in on them, particularly new meds, and then tell me how you're going to manage it back out in the community. And there's a bit of groaning with the assignment, but they generally really, really enjoy it. So I'm going to hop back over into the chat. to see if there's a question that I by chance have missed. This is weird. Not, you're not weird. You know what it is? The chat box just kind of froze on me. What do I mean by the survey restriction in AANP? If I said something like that, I'm not sure what you mean by it. Okay. And maybe that was directed to Brian and not me.
Yeah, I'm not sure, Dr. Fitzgerald.
Okay, you've taken care of that. Thank you. Okay, it was for Brian. I was like,
Oh,
what
okay.
the heck did I say?
And honestly, I'm posting material that's at the
Okay,
end
all
of the
right.
guide.
Thank
So
you.
you may want to take a look. Maybe that means more to you than it does to me. Can you see what's in the chat there that I posted?
Um, you know what? For whatever reason, the chat box keeps
He's
freezing on me.
freezing. Okay.
Oh, okay, okay. Gotcha. All right, thank you. And the yeah, those the information that Brian included in the chat is worth its weight in gold at those links. And please share those widely with your students. Looks like we don't have any questions. Again, I wish you all a wonderful Thanksgiving. Thank you, Mr. Austin, for holding down the fort and
Sure.
answering a question that I didn't know how to answer, but
And thank you, Dr. Fitzgerald. As
take
always,
care.
it's good seeing you.
Yeah, good to see you too. Take care.
All
Good
right.
night.
Take care now. Take care, everyone.